Hello everyone, and welcome to CRAMSURG, Clinical Research Appraisal and Methodology for Surgical Trainees, where we pick a paper fresh from the press on a hot general surgical topic. We review it for you, we present it for you, we critique its methodology for you, and provide top-of-the-field expert opinion and teaching on research appraisal and methodology. My name is Gio Perrin, and together with Professor Sababala Subramanian and Maria Digby, we bring you CRAMSURG from the wonderful region of the Yorkshire and the Humber. Welcome back everyone. Today we'll have a look at a very interesting paper about the use of tranexamic acid in general surgery. As you probably know, the use of TXA in elective procedures particularly has become more and more common, so we welcome this type of papers that look at the efficacy and safety of such a drug. I'll leave you to it.
Hello everyone, my name is Pratik. I'm one of the surgical registrars currently working in Rotherham Hospital, and I've got Sagar with me, who is one of our SHOs. And today we are discussing the safety and efficacy of tranexamic acid in general surgery, which is a paper which has just come out on the 15th of January this year. It's based in Canada, and looking at the title, this is of interest to us because we are dealing in general surgery. We've got a PubMed URL for you guys as well if you want to have a look at the paper yourself. And I'll hand over to Sagar to go through the aims and methodology. Sagar?
Yeah, thank you, Pratik. Hello, guys. So regarding background, so as we know that perioperative bleeding is common in surgery, which leads to longer recovery and more complications. So the aim of the POISE 3 trial was to demonstrate the efficacy of prophylactic TXA compared to placebo in preventing major bleeding without increasing the vascular outcomes in non-cardiac surgery. So now coming to our sub-study, the aim of the sub-study was to determine whether perioperative TXA affected the risk of composite bleeding or major cardiovascular outcome at 30 days after intervention among patients who underwent general surgery, and whether this effect differed from the patients who underwent different types of surgeries. So in terms of population, the general surgery cohort for the sub-study was made up of 3,260 patients from the large POISE 3 trial, and the intervention of interest was TXA, and the control was placebo, which was 0.9% normal saline. And the outcome that we were looking at was the safety and efficacy of TXA, and it was further divided into primary, secondary, and tertiary, which we will discuss later. And now we will move on to the method. So this study is basically a sub-study of an international multi-center triple-blinded RCT. And the original RCT, the POISE 3, they employed a partial 2x2 factorial design where they investigated two interventions simultaneously. First being a TXA versus placebo to assess the effect of TXA on perioperative bleeding. And the second was blood pressure management strategy, where they randomized hypertensive patient into hypertensive avoidance and hypertension avoidance strategy. And they mentioned in the paper that there was no interaction between the two subgroups. So now coming back to our sub-study, the inclusion criteria for it was the patients who were older than 45 years old, undergoing non-cardiac surgery and requiring at least an overnight hospital admission, and those who were deemed to be at risk of perioperative bleeding and cardiovascular complications. And the period of enrollment of the participants was from June 2018 to July 2021. And it was random block randomization, which was stratified by the center itself. And it was 1:1 randomization with the 1 gram tranexamic acid versus placebo was prescribed at the end and the start of the surgery. And it was modified intention to treat analysis. And there were certain methods that were adopted to reduce bias, such as blinding, triple blinding, which to reduce detection bias, and the stratification, randomization, and multi-center study to prevent selection bias, and then intention to treat analysis to prevent attrition bias. So moving forward to method. So there were certain exclusion criteria which you can find in the supportive material. they excluded the patients who were with congestive heart failure, with brain aneurysm, and with hypertension associated cerebral hemorrhage, and those who were undergoing surgery for pheochromocytoma or untreated pheochromocytoma, and the list goes on. And so now, initially there were like 1,93,450 patients that were screened for eligibility, and out of which only 2,605 were deemed eligible. And out of those 26,581, 9,535 were finalized for the main study. And for the sub-study, we excluded 67 patients based on the information received from the center responses, because some of the patients did not have the procedure, and we did not have data for few patients. And out of those final patients, like 9,468, they were subdivided into two groups, and 3,260 patients who underwent randomized under general surgery group, and 6,208 patients were randomized under non-general surgery groups. Now, I'll hand over to Pratik to discuss the outcomes and results further.
Thanks, Sagar. So the outcomes of interest are primary outcomes. They were interested in an efficacy outcome and a safety outcome. And both of these outcomes were composite outcomes based off some components. And if patients scored for any of these components, they would score for the composite outcome. So the efficacy outcome was a composite of life-threatening bleeding, major bleeding, and critical organ bleeding. The safety outcome was a composite of myocardial injury after non-cardiac surgery, non-hemorrhagic stroke, peripheral artery thrombosis, and symptomatic proximal VTEs. Definitions of everything is available in their supplementary material. Secondary outcomes included individual components of safety and efficacy outcome, bleeding independently associated with mortality after non-cardiac surgery, and transfusion. The tertiary outcomes included next risk-benefit outcomes as a composite of vascular death, non-fatal life-threatening major or critical organ bleeding, stroke, peripheral arterial thrombosis, to name a few. Now, looking at the baseline characteristics of the patients, we can see that the patients under the general surgery cohort, for both the TXA and the placebo arms, their baseline characteristics are very comparable. Of note is patients who were hypertensive are about 90% in both groups. And also of note is the lack of any mention of patients who were taking anticoagulation or antiplatelet medications in any of these baseline characteristics described. Looking at the results for the primary safety and efficacy outcomes, on the left they have mentioned the efficacy outcome, which shows a composite bleeding outcome for general surgery is less when tranexamic acid is used than the placebo, with a hazard ratio of 0.74 and a p-value of 0.01. And in non-general surgery patients, they have observed the same effect. Again, coming to on the right side, they have done the composite safety outcome, where both tranexamic acid and placebo groups did not show any difference in the safety outcomes for general surgery as well as non-general surgery patients. However, looking at the bottom of the right-hand side table, we can see they have mentioned that they have looked for seizure activity for tranexamic acid versus placebo, and on the non-general surgical group, they found a hazard ratio of 8.11 with a p-value of 0.5 with 95% confidence interval. This is significant, although the effect size is very small here. However, they did not mention this in their main text. They've done a forest plot which shows that for both general surgery and non-general surgery groups, the primary efficacy and safety efficacy outcomes favor tranexamic acid, and for safety outcomes, they are comparable to both tranexamic acid and the control group. So summarizing the outcomes, we can see that there is significantly lower risk of composite bleeding outcome reported in this study for the tranexamic acid group, and no difference in composite safety outcomes between tranexamic acid and placebo groups. The secondary outcomes mention that in the tranexamic acid group, there is a reduced risk of BIMS and reduced risk of receipt of one or more unit of packed RBCs, and less bleeding according to the International Society on Thrombosis and Hemostasis definition for major bleeding in the tranexamic acid group. Subgroup analysis show for hepatobiliary and colorectal surgery, there is statistically significant lower risk of composite bleeding outcome with the TXA group, and they have done a p-value for interaction which was not significant. They have also seen that those who underwent head and neck procedure in the TXA group had a lower risk of experiencing an event in the composite safety outcome. However, the p-value for interaction here was significant. Other key findings reported were within the general surgery subgroup, there were no difference between TXA and placebo groups regarding need for transfusion of 2 or more packed RBC or 2 to 4 packed RBC units. There were no statistically significant differences among subgroups in general surgery cohort regarding other tertiary outcomes, including all-cause mortality, vascular mortality, infection, and sepsis. The effects of tranexamic acid versus placebo on the primary efficacy and safety outcomes were not modified by cancer status within the general surgery cohort, and the p-values for interaction are 0.21 and 0.48 respectively. So coming to the limitations, the self-reported limitations are that this is a subgroup study which was not powered for subgroups and subcategories that have been explored in the original RCT. And there are variations in bleeding risk across the subcategories of the general surgery that they looked at. For example, they've looked at hepatobiliary, colorectal, general surgery like lap choles, and also included head and neck in this group of patients with general surgery. So there is a lot of different kinds of operations that they have looked up in this one group. And they mention hemostatic management, including transfusion triggers, may have varied between the surgeons and institutions. The other limitations that we feel in the paper are that they did not mention any protocol regarding anticoagulant use or disorders of coagulation or bleeding in the study groups, which could independently predispose to increased bleeding or thrombotic events. Then we look at generalizability, and with this regard, they have included patients who are more than 45 years of age and had to meet predetermined strict criteria predisposing them to increased risk of bleeding and increased cardiovascular risk. This is all mentioned in their study protocol for the original RCT. And the other thing being that their general surgery includes head and neck surgery, which is not usually the case in the UK. External validity, there is variability in dosing and timing in the UK. In NICE, they mention using tranexamic acid for trauma patients as a loading dose and then an infusion over 8 hours. However, in this study, they have used 1 gram of tranexamic acid at the start and at the end of the operation, so 2 doses. Although the RCS came out with a statement about 2 years ago for considering patients who might have more than 500 mils of blood loss for the same protocol. However, that was based on the results of the POISE-3 trial, which were published around that time. And also, there was a national sort of shortage of packed cells. The other thing we feel is that in the non-general surgery, significant increase in seizure risk has been shown statistically, and that should have been talked about in the paper, especially because there are reports that tranexamic acid has association with seizure activity in the literature. So the bottom line is the prophylactic TXA could have beneficial role in preventing major bleeding in general surgery. However, further studies with broader inclusion criteria are needed to inform a change in current practice. So we feel that the good things about this is it is a sub-study based of a international multi-central RCT, which was triple blinded, Bad things about the methodology is it was not powered for this sub-study in the original design. There is variability of hemostatic management, thromboprophylaxis, perioperative anticoagulant or antiplatelet use which could potentially influence the results. And this partial factorial design, which was not mentioned in the text of the study, which could also potentially influence the result. In the original RCT, this showed that there is no interaction between TXA versus placebo and hypotension avoidance versus hypertension avoidance factors. However, they have not mentioned that in this sub-study, which could have some effect. Looking at the clinical domain or expertise, the good things, we think it shows significant reduction in bleeding in the TXA group and no significant difference in safety outcome measure between the two groups. However, and this is relevant to us practicing in general surgery. However, the bad things are that coagulation or bleeding disorders and anticoagulant use were not accounted for. As we talked about previously, there is reduced generalizability and reduced external validity, and also the fact that they failed to mention that in the non-general surgery group, there was a significant increase in the seizure risk with TXA. Thank you. That's the end of the presentation.
Excellent. So, as we did last time, we're going to talk about statistical tests today. And I'm going to talk about students' t-test and a brief chat on scarcity and what it means. So similar disclaimers to last time. I'm not a statistician and I'm not an expert in stat software. I read about both and I kind of do a little bit of both every now and again and when I can. Let's start with a brief summary of what we did last time. So last time we introduced the concept of assumptions, what they are, and to very briefly reiterate, they are a relevant piece of information about your data and a rule that must be fulfilled in order for the test that you're choosing to do to be valid. We talked about probably the most important assumption out there, the assumption of normality of the data, and how to look for it and how to test for it, which again we did last time by simply looking at the numbers, looking at the way the data shows on a chart, and also doing a Sheffield-Wilk test. So today we're going to carry on our plan. We're going to carry on continuous data, and we're going to look at normally distributed data. In particular, we're going to look at the two groups, and particularly we're going to look at a t-test for non-paired samples. And we're going to do that again using Jamovi as a demonstration. So a little bit of history for myself and for this test. These are my two university professors of statistics and the people that introduced me to the students' t-test and its history. So I thought I should give them a shout out here. They used to have a picture with themselves in front of the Guinness factory, but I couldn't find that one, I'm afraid. So why the Guinness factory? Well, because students' t-test was born out to work that was done at Guinness a long time ago, now over a century ago. And it has to do with barley quality testing and making sure that the beer that comes out of your factory is of good quality, which we all know is very important. So basically the question that people at Guinness were asking themselves is, I have 2 batches of barley. How do I find out if they are different without testing every single grain? And that's where all the story about students' t-test started, particularly with William Gossett. And as I said, this is a very old story, starts in 1908. And Gossett was a pioneer of quality control and quality assurance, if you like, in the brewing industry, but also in other contexts, you would say in statistics in general. And he published a paper in Biometrica. If you Google Biometrica students' t-test, you can still find his, obviously, a PDF copy of his original paper. And when he published the results of his technique, because of very strict rules that were imposed that Guinness at the time, he couldn't use his own name because Guinness was worried that other breweries and other industries would steal their industrial secrets. So he published it using the pseudonym Student, hence why the test is called Student's Tea. So to translate the problem about barley into something a bit more generic, we could say that the problem that Student was trying to sort out was, I have two samples representing two independent populations. How do I know if they're truly different from each other? And as we said, this is roughly where we sit in this context. And I mentioned earlier on, we're going to talk about non-paired t-test, because the samples that we're talking about come from two different populations. And we'll have an example of that. What does it mean when we talk about paired samples? Well, it means that we effectively are taking a piece of data from, for example, the same person at two different points in time. For example, I take a sample of 40 men, I measure the blood pressure, then I give them a tablet to correct it, and then I measure it again. Those samples are paired. They're associated with each other. Let's talk about the assumptions that lie behind the Student's Tea. So, as we said earlier on, some truth about your data that have to be fulfilled for you to reliably run the test and for the test to give you a reliable result. So the assumption number one is normality. So we talked about it, and it is pretty much always the first assumption you need to check for. So I'm not going to go into too much details about that. The second very important assumption has to do with skedasticity. Particularly, this test should be used only if your data is homoskedastic. What does that mean? Well, it means that the variance of the populations that you're testing fulfill a certain rule. I'll try and give you a graphical example, very simple. You can have two identical populations. They have the same mean and they have the same variance as the one you see on the left. You can have two populations, as you can see here, they have the same mean, but they have a different variance. You can have a population that have different means, but have the same variance. Now, in order to use Student's t-test, you have to be in the rightmost situation. So your two distributions have to have a comparable variance. The test is, as they say, robust to a degree of variation from this truth. However, if the variances are really different between the two populations that you are trying to compare, you shouldn't be using this test. You should use something different. So homoskedasticity is the scenario to the right. Okay. There are further assumptions that are probably relatively logical. The samples have to be randomly extracted from the populations. The samples have to be big enough. Now, how do you define big? This is a bit more difficult. If you look around, most of the opinion seems to say that if you have at least 40 observations per group, you should be able to use this test and it should be reliable enough. And the two samples, as we said, they have to be non-paired. So, a quick recap before we go into a practical example. To use this test to determine whether two populations are different, we have to have two samples of continuous data from such populations. The data has to be normally distributed, and the two samples have to have comparable variances. So let's go back to my dissertation data set as we discussed last time. As part of my dissertation, I collected some data about papers that were advertised on Twitter by the publishing journals. So the question I'm asking today, and I'm trying to answer is there a difference between medical and surgical papers in terms of retweets? So I've got a continuous variable, the number of retweets, that I have collected for medical paper and surgical papers. And these two groups are different from each other. So it's a non-paired test. So let's have a go. Similarly to last time, we're going to load this lovely data set. I apologize for my voice today. Unfortunately, I have no control over it. So let's start with something very, very simple, right? Let's check, first of all, if what we want to do makes sense in terms of our assumptions being fulfilled. Let's start by doing some data explorations and some descriptives. I said that I wanted to see if retweets are different between medical and surgical papers. So I'm going to pop retweets here, and I'm going to split it by surgical or medical. And Jamovi straight away gives me a bit of information, as you can see. Probably the thing I want to look at first is this data normally distributed? What's the difference between mean and median? Well, it's pretty massive. More in medical papers rather than in surgical papers, but still pretty massive. So this data is probably not normally distributed. We can see that even more if we use a histogram, even if we do a bit of density there. You will see straight away that the data is skewed. We can do more things here. We can check variances. As you can see, put it there. There is a slight difference there, as you can see. And you can also do that. It will give you additional information about the data. Okay. Now, let's assume, and obviously we can run the Sheffield-Wilk test as we did last time, which suggests that, again, the data is very much not normally distributed. But for the purposes of doing this demonstration, we are going to ignore all of this and pretend that the data is normally distributed. And we're going to move on to do a t-test. And we're going to do an independent samples t-test. And similarly to what we did a second ago, we're going to take retweets and we're going to put it here. And we're going to take our surgical or medical as a grouping variable. We're going to put it there. And as you can see, Jamovi spits you out a beautiful p-value. It does also give you a fair warning that probably this is not the test you want to run on these samples. And you can also check for assumptions. Particularly, you can do a normality test, which is what we did last time, straight from here, very handy. You can also do an homogeneity test, which is a test that checks if the variance between the two populations that you're studying is similar or not. And as you can see, it definitely isn't. So we have seen how easy it is to actually run a sample, a t-test. We've also seen how easily Jamovi tells you to be careful about the data you're analyzing and how he prompts you to look for your assumptions and making sure that you're taking them into account, which is one of the reasons why I love it as a software, because it's very easy to teach and to understand also what's behind it, what's behind all the statistics, at least to an extent. Thank you everyone for tuning in and listening. Until next time, keep running your life with our surgical podcast.